Good morning. Today I will be taking class about cerebrospinal fluid analysis. What is a CSF? CSF is present in the subarachnoid space surrounding the brain and the spinal cord in the spinal column. The normal volume of CSF in adult is 140 to 170 ml. For children it is 10 to 100 ml. CSF is secreted by the choroid plexus, and from the choroid plexus it moves into the lateral ventricle 1 and 2 through the foramen of the Mandro, third ventricle, aqueduct of Sylvius, reaches the fourth ventricle, foramen of the Lashka, and then reaches the subarachnoid space. The CSF is reabsorbed by the arachnoid villi. What is the functions of the CSF? It provides physical support, mechanical cushion to the brain. It transports the nutrients and the waste products between the brain and to the blood, and it auto-regulates the intracranial pressure. Formation and composition of the CSF. CSF is nothing but ultrafiltration of the plasma. It is secreted in the choroid plexus, and then if through the foramen and ventricles it reaches the subarachnoid space. The CSF is reabsorbed by the arachnoid villi. 500 ml of fluid is secreted each day. Composition of the normal CSF. Normal CSF mainly you have to remember protein and the glucose. Normal reference range is 15 to 45 mg per deciliter for protein, glucose 50 to 80 mg per deciliter. And then coming to the cells, cells is 0 to 5 cells are present in the CSF fluid and all should be lymphocytes. What are the clinical applications of the CSF examinations? Clinically, why we need to do CSF examination? Mainly for indication is bacterial, viral and fungal meningitis, subacute sclerosing panencephalitis, meningoencephalitis, subarachnoid hemorrhage, intracranial hemorrhage, and in case of malignant infiltrates, to know whether any malignant infiltrates is present in the brain or not. And in case of therapeutic, for introduction of drugs, for example in case of any drugs you have to specific to the brain, you can do it with the introduction of drugs through the CSF, spinal anesthesia, introduction of the serum to decrease intracranial pressure. And contraindications. What are the contraindications of CSF examination is brain abscess, septicemias, patient with convulsions, raised CSF pressures, and in advanced cardiovascular disease patients. What are the normal characters of the CSF fluid? Color is generally colorless, pH 7.28 to 7.32, appearance will be clear, specific gravity is 1.003 to 1.004, and there should not be any clot formation. Okay, how will you do the CSF? How will you collect the CSF? CSF is collected by the lumbar puncture needle. It is a slender needle 10 cm long with bore 1 to 1.5 mm. What you have to do is ask the patient to lie on one side and ask him to pull the knee till his chest wall through the lumbar puncture needle. Insert the lumbar puncture needle in the spine between third and fourth lumbar spine. Go in forward and upward direction. You will feel a giveaway feel, that is you won't feel any resistance. There you have to collect 3 to 5 ml of fluid. When you are collecting the 3 to 5 ml of fluid, look for the pressure. Pressure should be normally 90 to 180 mm of water. Okay. Once you have collected, you have to process the sample within 1 hour, because CSF once if the process is delayed, then the cells will be degenerated. So you have to process the CSF fluid within 1 hour. The collected CSF sample should be separated in 3 tubes. One tube should be sent for biochemistry and immunology, one tube should be sent for microbiology, and tube 3 should be sent for cell count, DC and cytology. Okay, so what are the routine lab tests? Routine lab tests is normally you have to look for opening CSF pressure when you are collecting the CSF sample. Macroscopic examination, that is look for the color, viscosity and then clot formation, and then microscopically look for the total cell count, DC and cytology, and then you have to look for the glucose and the protein estimation. What are those optional? This one optional lab testing will be culture, gram stain, cytology, enzyme, electrophoresis, VDRL test. It depends upon the physician's request. Okay, first one is CSF pressure. Normal CSF pressure is 70 to 180 mm of water. Children's have 20 to 100 mm of water. Decreased pressure is noted in case of circulatory collapse, spinal canal block and dehydration. Increased pressure is noted in case of meningitis, encephalitis, cerebral edema and hemorrhage. Coming to the gross examination, normal CSF will be clear, colorless it will be, and the viscosity will be that of the water. If the viscosity is increased, then it shows that the CSF is having more protein content, and clot should not be seen. Suppose if you are seeing the clot, then look for the nature of the clot. Suppose if it is a delicate clot, then like cobweb appearance, then it is mainly because of tuberculosis, tubercular meningitis. If there is a coarse clot, that is pyogenic, it is mainly because of the pyogenic meningitis. So how will you look for the clot? take the CSF in a sample, take the CSF in the test tube, allow you to stand overnight, look for the clot. If the clot is present, look for the nature of the clot. If it is delicate, fine, it is because of cobweb appearance, it is because of tuberculosis. If it is coarse, then it is because of the pyogenic meningitis. Now, xanthochromia. What is xanthochromia is pink, orange or yellow discoloration of the CSF fluid. It is mainly because of the RBC lyse or hemoglobin breakdown. Causes include spontaneous subarachnoid hemorrhage, intracerebral hemorrhage, associated obstructive jaundice and spinal tumor. See, in this, if you see, you are seeing the pinkish, orange or yellowish discoloration of the fluid. This is mainly because of the RBCs in the CSF fluid have been lysed. It is more commonly associated with the obstructive jaundice. Remember, obstructive jaundice is the main cause for the xanthochromia. Now, coming to the microscopic examination, normally WBC count should be 0 to 5 cells and all the cells should be of the lymphocytes. So, how you will count the CSF cell? Now, you take the mix the CSF sample, take the CSF sample and mix it and dilute it with the diluting acid in the ratio 9:1. Charge it in the Newbar chamber, and in the Newbar chamber you have to count the 9 squares. Once you have counted in the 9 squares, when you have counted the cells, then you have to, with the formula, number of cells you have counted in the 9 squares into the depth, into the dilution, you should calculate and you should write the total cell count. Okay, so CSF fluid you will dilute in the ratio, CSF fluid sample you will dilute in the ratio 9:1, charge in the Newbar chamber, count in the 9 squares of the Newbar chamber, then apply in the formula, that is number of cells counted in the 9 squares into depth into the dilution. That will give you the total WBC count. Okay, generally it should be lymphocytes. Suppose if you are seeing more number of cell count, that is more than 5 cells, but predominantly if you are seeing neutrophils, then you have to think of bacterial meningitis, early tubercular, fungal and viral meningitis. Suppose, see, in this you are seeing more number of cells with more predominantly neutrophils. So, it is mainly of bacterial meningitis. Suppose same situation with lymphocyte predominant, it is of viral meningoencephalitis and aseptic meningitis. Here you are seeing predominantly lymphocytes. And suppose if you are seeing more number of eosinophils, then it is because mainly of parasitic or fungal infections. Then plasma cyto, if there is more number of plasma cells in the CSF, then it can be because of TB meningitis or syphilitic meningitis. More number of plasma cells is seen and it can be because of TB meningitis or syphilitic meningitis. Now coming to the chemical examination, normal CSF is 20 to 45 mg of proteins. Albumin globulin ratio is 8:1. So, okay, now if you are seeing this protein, suppose alpha-2 macroglobulin is increased, then it can be because of subdural hemorrhage or bacterial meningitis. If beta amyloid and tau protein are increased in the CSF fluid, then it is because of Alzheimer's disease. If beta-2 microglobulin is increased in the CSF, then it is because of the leukemia. Similarly, now we have seen the protein normal reference range, and if the proteins are increased, which disease is associated, I have told you. Now coming to the enzyme, if adenosine diaminase is increased, then it is because of the meningeal tuberculosis. If creatinine kinase is increased, then it is because of hydrocephalus and subarachnoid hemorrhage. If lactate dehydrogenase enzyme is increased in the CSF fluid, then it indicates it is because of CNS leukemia, metastatic carcinomas or lymphomas or meningitis. In case of coming to tumor markers, carcinoembryonic antigen is associated with the brain tumors. Coming to electrophoresis method is applied in the CSF fluid to know to rule out the multiple sclerosis. Generally, patient affected with multiple sclerosis will get 2 or more discrete band, which indicates that the patient is having multiple sclerosis. Now coming to the glucose estimation, remember protein and glucose are the two important tests you have to do routinely for all the CSF fluid. If glucose estimation is done by the glucose oxidase method, CSF glucose is generally should be more than 40 mg per deciliter. Increased CSF glucose, no need to worry. Decreased CSF glucose is always associated with meningitis and tumor. Okay, coming to the bacterial meningitis, which common bacteria affect the age group? 0 to 1 month, most common bacterial organism is group B, streptococcal and E. coli. 1 month to 5 years is Haemophilus influenza. 5 to 29 years is Neisseria meningitis, and more than 29 years it is Streptococcus pneumonia. This is a flowchart which shows the difference between the bacterial, viral and fungal and tuberculosis. Coming first to the opening pressure, in bacterial it will be elevated, whereas in viral, fungal and tuberculosis it is normal. Leukocyte count is more increased in bacterial meningitis, that is more than 1000 per microliter is seen in bacterial meningitis. Like less than 100 is seen in case of viral, and for fungal and tuberculosis it is variable. Protein is increased in all the four, and glucose is generally reduced in the bacterial meningitis. Generally it is less than 40 milligram per deciliter in bacterial meningitis, whereas in viral it is normal. Cells predominantly neutrophils in bacterial, viral and fungal and tuberculosis it is of lymphocyte. So if you are seeing the leukocyte count is highly increased, with glucose level is decreased, and predominantly neutrophils it is of bacterial meningitis, and in case of viral meningitis it is predominantly lymphocyte, and the cell count will be less than 100 cells per microliter, okay, and the glucose will be normal. So generally glucose lower is associated with bacterial meningitis. Coming to the neurosyphilis, VDRL test in the CSF fluid is necessary to rule out the neurosyphilis. So in CSF you have to do the VDRL test, which gives you 100% specificity, okay. And in case of viral meningitis, enterovirus, ecovirus, Coxsackie, polioviruses are common viruses. And then in case of cytomegaloviruses and herpes simplex, you can see viral inclusions. Generally PCR technique is applied for herpes simplex virus, and usually brain biopsy is also required to detect the meningitis because of the herpes simplex virus. Okay, so HIV is associated with increased lymphocyte, elevated IgG, and in case of fungal meningitis you can also see histiocyte response. That is fungal meningitis, it will be associated with increased lymphocyte, histiocytes can also be seen, and India ink stain is mainly applied for cryptococcal fungal infections. Coming to tuberculous meningitis is difficult to diagnose in the early stage. High level of adenosine deaminase enzyme is noted in case of tuberculous meningitis. ELISA and PCR technique is now done for tuberculous meningitis, and acid fast stain is also used in tuberculous meningitis. Coming to CSF cytology, what is CSF cytology is to know whether the any malignant cells is present in the CSF fluid or not. What are the common malignancy associated with the CNS is lymphoma, leukemia, meningeal carcinomas, and spread from the primary tumor. Okay, what you have to do is, once you have got the CSF sample, you have to cytocentrifuge the CSF sample, prepare 3 slides with 3 stains, one is HND, PAP and MGG. Okay, then you have to look the cells. Suppose if the patient is having leukemia, CNS leukemia, then there will be increased number of blast cells will be seen. Then if the patient is affected with lymphomas, more number of lymphoid cells, excess lymphoid cells with large tumor cells can be seen in the lymphomas. And metastasis from the other side. Suppose if a patient is having lung tumor, if the carcinoma has metastasis to the brain, you can see increased cellularity, more number of cells will be there with increased with irregular nuclear margin, with high NC ratios, with prominent nucleoli. These can also be, these are the features which are seen in the malignant tumors, metastasis from the primary site. Here if you are seeing, this is a CSF sample in which you are seeing more number of blast type of cells. So it is leukemias. Okay. So diagnosis by CSF, bacterial, TB and fungal meningitis, there will be high sensitivity. All these 3 type of infections, bacterial, TB and fungal infections, can be easily detected by the CSF fluid. Viral meningitis is of moderate sensitivity, and in case of meningeal malignancy, moderate sensitivity. The moderate sensitivity means there is a chance to miss this diagnosis in the CSF fluid. Now coming to the other fluids. Other fluids are the pleural fluid, peritoneal fluid, pericardial fluid, synovial fluid. Okay, so pleural fluid is a fluid accumulation in the pleura, between that is pleura around the lungs. Okay. Generally this fluid gets accumulated in the body cavity by means of 2 processes. One is transudate and the other is the exudate. Transudate means either that is increased hydrostatic pressure or decreased oncotic pressure. For increased hydrostatic pressure, example is congestive heart failure, and for decreased oncotic pressure is liver cirrhosis. Coming to the exudate, inflammation, infection, infarction and tumor can be seen. So generally if you are getting a sample, suppose if you are getting a fluid, you have to rule out whether the cause is because of transudate or exudate cause. Transudate is mainly because of congestive heart failure, liver cirrhosis, malnutrition. Exudate is mainly because of the malignancy, infection, inflammatory condition. You have to difference because exudate causes associated with the malignancy. So how will you differentiate is, coming to the differentiating point, transudate, the gross appearance will be clear. Exudate, it will be turbid or cloudy. Specific gravity will be less in case of transudate, more in case of exudate. Protein is less than 3 mg per deciliter in transudate, more than 3 mg per deciliter in exudate. Clot is absent in transudate, present in the exudate. Generally, you will see benign cells in transudate, and in case of exudate, malignant cells can be noted. Why you want to take, what are the indications for effusion cytology is to rule out whether any malignant or pre-malignant condition is there, and to know whether inflammatory, infective conditions like TB or anything is present. Okay, now coming to the examination of the body fluid, again same thing like CSF, you have to look for the gross macroscopic picture and then microscopic. Macroscopy is what means you have to look for the clear color, turbidity, viscosity, clot formation. Microscopically you should look for the cell count, then you have to look for what type of cell, DC cell and cytology, that is presence of malignant cells or not, and any other special test, which includes enzymes, chemicals or microbiological test. Sample is collected by FNAC technique or by the method called tapping. Okay. So what are the type of staining? Again you have to do pap stain, HND stain and gram stain to look for the gram positive or gram negative bacteria. Cell block can be done. If cell block is done, it is very good because it can be taken for the histopathological examination also. So coming to the pleural fluid is formed by the transudate or exudate. Lab analysis, the same thing, gross examination you will do, cell count, which type of cell is present, and the cell which is commonly seen in the pleural is called mesothelial cells. Mesothelial cells will line the pleural lining. So you can see the mesothelial cells in the pleural fluid. It is normal to see. RBCs and WBC, if the RBC, you have to rule out whether it is a traumatic tap or not. If it is a traumatic tap, whether if it is not because of the traumatic tap, then it indicates there is a infarction. Okay, next is the peritoneal fluid. Abnormal accumulation of the fluid in the peritoneal cavity is called as ascites. Ascites is a condition in which fluid accumulates within the peritoneal space, must have accumulation of more than 100 ml, which so that it can be detected on physical examination. The method by removal of the peritoneal fluid is called as paracentesis. Again you have to distinguish between transudate and exudate cause, and you have to look for the clear color, clarity, everything you have to look. Cell count you have to do, and you have to do you look for the number of cells, which cells is predominant. Lymphocyte is predominant in CHF, liver cirrhosis. Here also you can see the mesothelial cells. Mesothelial cells seeing in the pleural and ascitic fluid is normal. And you have to look for any malignant cells or there. Malignant cells we will see more number of cells with irregular nuclear margin, pleomorphic nucleus, and increased NC ratios, prominent nucleoli. Next is the pericardial fluid. Accumulation of the fluid in the lining of the heart is called as pericardial fluid. The main cause will be neoplasm, infection, collagen disease and renal disease. Gross examination, you have to look for the clear viscosity, color viscosity. Again you have to look for the pH. Cell count, if there is any traumatic tap, then there can be RBCs. If the traumatic tap is not, if you are ruling out the traumatic tap, then it is because of the infarctions. Okay. Next is the synovial fluid. Synovial fluid is a normal, clear, viscous fluid. It functions as a lubricant and transport the nutrients. Orthocentosis is a aspirate. You are removing the joint fluid is called as orthocentosis. Again the same thing like gross examination, microscopic examination, gram staining cultures to look for any organism, any specific organism is present or not, to look for that. Okay, then one more test is called as mucin clot test, which is specific to that of the synovial fluid. And then slide examination, same thing like number of cells, malignant, if any malignant cells are there, you have to look. Okay, so these are these fluids. One is CSF fluid, pleural fluid, pericardial fluid, peritoneal fluid, and then synovial fluid. Okay, this finishes the class. Thank you.